In today's lecture, we're going to be talking about the top 3 consults that we get in ophthalmology and what happens after we see the patient. So this is a whole gambit overview, mostly for beginning technicians or primary care providers that have questions about eye problems that are the most common things seen in the urgent care or primary care setting. So, without further ado, we'll start it. So, the 3 most common categories that we're going to be talking about today are diabetes, because that's a pretty common problem that we see in ophthalmology. 2, blurry vision for the patient that's over 60. And number 3, which is the broadest category of all, and that's the red eye consult. Next slide. So, the primary care provider, this relationship is really important because the primary care understands the patient. They know the patient's past medical history, some of their social and environmental roles that play a big portion of the patient's health situation. And as a primary care provider, they're the ones that really help navigate and help the patients into the right clinical practice. Some problems are best served by referring to a retina specialist. Some are best served referring to an optometrist. And depending on what you're seeing with a patient, helps you understand where is the best situation for this patient to go to. Okay, going back to the normal eye, for a diabetic patient that gets referred to an eye doctor, most of the time, hopefully, it's a normal examination. We look at the nerve and the blood vessels, and we're looking for pathology. So a lot of the screening for diabetes can go to just a general eye doctor or an optometrist, and we're hoping that on that examination, it is a healthy eye. Let's go to the next one. So over time, these are the capillaries. When there's damage to the capillary blood wall, there's the formation of pericytes. There's the loss of pericytes. When there is loss of pericytes through ongoing damage from diabetes, we start to get microaneurysms, and that's the first clinical phase. Even if there's just a couple microaneurysms, we really don't initiate treatment. It's when things start to get a lot worse that's when we intervene with therapy. So here's some more pictures. You can see a microaneurysm. This microaneurysm and this one have opened up. And when the microaneurysms burst, that's when we get some more of the retinal hemorrhages on the examination. Microaneurysms also cause leakage into the retinal space, and that causes macular edema. The hard exudates that we see clinically often point to damaged capillaries. Now, this points to our last lecture, if you haven't seen it, on diabetic retinopathy as an overview. But in this situation, we see the nerve, the blood vessels, and then the hard exudates here in the temporal macula. This is a patient that probably has more moderate stage diabetic retinopathy and macular edema, and these are the ones that start to require therapy with injections or laser. This is the injection right into the eye. No one wants to hear that as a patient, and sometimes it helps motivate them to do a little bit better on their diabetic control when they hear that word. We might need to do a shot in your eye. Some of the cases we also start not just injections, but we start to combine the injection therapy with laser. Diabetic retinal laser is an argon laser typically, and that includes both macula and peripheral panretinal photocoagulation. In the really severe stages, the patients with diabetes that have hemorrhage or tractional retinal detachments have to go on to a vitreoretinal surgeon for vitrectomy. So that's kind of a broad overview on diabetes. Hopefully when you have a patient with it, they have no retinopathy, and they can just do a yearly screening test. So the next category is blurry vision for the patient 60 and over. And you can kind of split this into two categories. The first category, cataracts, and the symptoms for this are hazy vision, glare, halos. And the next category of patient is the macular degeneration patient, and these are going to have more central decline in vision, distortion, or even blind spots or scotomas. Cataracts, here's a picture of one of our patients. They can get quite large if left untreated, and these are the ones that have a lot more debilitating vision loss. Sometimes we get these consultations when the patient fails their DMV test, and those are the ones that we love to help, because by removing the cataract, we get them back on the road and they regain their independence. Here's surgery. Just a picture of surgery. There's two different ways to do the surgery, and if you haven't seen the lecture on cataract surgery, what are our techniques, you can review that. But here's an example. We do it either by hand with an ultrasound, or we use a laser to do the surgery. Here's a picture of the two techniques side by side. One on the left is by hand, one on the right is with the laser. So that would be it for that. Here's one of the devices that we now use in surgery. It's called the Aura, and now with all high-tech properties, we can, in the middle of surgery, measure patient vision to hone in on the best lens implant for surgery. You can show that quick animation. It's got an internal laser that attaches to the microscope, and then in the middle of surgery, we measure vision with the laser. We can move on from there. All of this is in the cataract lecture. There's a picture of a lens during surgery being implanted, and you'll see it rolled up. As it's inside the eye, then it unfolds, and we can use a little tool here to help guide the lens right into the correct spot and open up the two arms that hold it in position. So pretty neat. That's what we see during surgery. There are different lenses. Here's an example of a lens that we would consider an advanced technology lens. This one has alternating rings of focus, so it allows the patient to have three areas of, or zones of focus: near, intermediate, and far. The next category of vision loss for the 60 and over, we'll go into a little bit more detail, is macular degeneration. So remember, those are the ones that have gradual or sometimes rapid loss of vision. So I kind of break it down, and people will ask, well, do I have the wet or the dry type? It's important to distinguish the two. The dry type is slow and progressive. So think of it like the tortoise. Gradually, when we tell patients over the next 10 to 20 years, when you have the dry type, you would expect the vision to gradually decline. So that in the end stage, some of the more severe cases of dry macular degeneration, they're not able to read a book anymore. They're not able to see detail anymore, but they still keep their peripheral vision. The wet type is rapid and progressive, so that's why we have a picture of the rabbit. It can happen quickly, even overnight, even within a few days, to rapidly cause a decline in vision. And we distinguish the two both on prognosis and expected natural history, and also on treatment, because the two are treated slightly differently. Here's a picture of dry macular degeneration. So you look at the nerve, the blood vessels, In the very center macula, you see these yellow deposits. Those are drusen. And drusen are one of the characteristic findings that we look for in a patient with macular degeneration. So here's another picture. Same thing, we have the drusen. But in this case, there's also, hard to tell on the slide, there also is hemorrhage. So the word wet in macular degeneration implies there's either fluid or hemorrhage inside the macula. And that tells us there's an abnormal blood vessel or a choroidal neovascular membrane that's causing leakage or bleeding into the macula. So intravitreal treatment, historically, there's many different types of injections. Lucentis, Eylea, Avastin, some of the more common ones you might hear patients are receiving. So, now that we covered kind of a broad overview of those two, diabetes, blurred vision over 60, we'll go over the bigger topic, which is the bulk of this lecture, and that's red eye. So, there's books written about red eye. There's so many diseases that can do it. How do you organize it? And I thought about this, and in my mind, the best way to understand it is to give case examples, give pictures, because how do you otherwise memorize this? So we're going to give a couple examples, some photos, and that's going to help narrow down what's causing it. Here we go, ready for the cases. Case number 1. This is a patient that has had pain for 6 hours. And so you know this is a new onset acute pain. They'll tell you they feel like something's in the eye, and you can, even with the pen light, already tell something's wrong here. Can you see it from there, Jocelyn? There's a there's a foreign body in the eye. Now sometimes it's pretty clear. Let's say it's a welder or it's someone working in their yard. And there you have it. These, you just have to get rid of that foreign body. Let's go to the next. It can come in different forms. This one, here's one. So what we do is we bring them to the slit lamp and we remove it. A lot of urgent cares or emergency rooms that have a slit lamp, they do have the capability to remove these. And that's hopefully what you do. You just remove it. If you look at textbooks, you can use like a 27 or a 25 gauge needle to help from an angle flip it right out of the cornea where the foreign body is embedded. Sometimes, let's say if it is a metallic foreign body, you also have to use a burr or brush to brush away any of the little metallic fragments so it doesn't rust. Also, we always have to remember about tetanus. If it's metal, make sure that's updated. And let's go to the next slide. We'll often give them an antibiotic, but here's an example. You take from an angle. That way, if the patient moves forward or back, you're not going to puncture the eye. You're coming at a side. Always, and this is what we tell residents when they're training to do this, always have a Q-tip ready. I like to have a wet and one dry Q-tip ready because when you flick it out with your 27 gauge, it's going to swim around in the eye. So you have to be already ready to catch it with the Q-tip. And some of the foreign bodies are a lot easier to cling to a dry Q-tip, and some they cling better to a wet Q-tip. So I have both ready just in case. All right, questions on that one? Okay. We go to case number 2. This is a patient. They call and they say, I woke up, I look in the mirror when I'm brushing my teeth, and oh my goodness, my eye looks horrible. It's like a Halloween horror movie. My eye looks horrible. Please help me. And you ask, any vision change? No. You ask, any pain? No. It just looks bad. And the most common reason for this is subconjunctival hemorrhage. So here's a couple more pictures of it. You have a little one, different stages. Sometimes the more severe ones go all the way around the eye, and normally this is a benign condition, and we just reassure the patient. After we check everything out to make sure there's no deeper trauma to the eye or deeper hemorrhage, we give it time. And like any bruise, they go away after a week or two.
What is it called?
Subconjunctival hemorrhage. In my notes, you'll see it as SCH because it's a lot easier to write SCH than subconj hemorrhage. Okay, case number 3. Pain, redness. It's 3 hours. And something doesn't look right here. There's subconj hemorrhage all the way around the eye, and there is some type of abrasion here. There's something bad going on. Let's go to the next slide. In these cases, they'll usually tell you a story of trauma, like they were brushing their hair and bopped themselves in the face. We had a patient last month say she was trying to put her sunglasses on when she got out of her car and she was in a rush and poked her eye with the sunglass. Sometimes they're out gardening, but that trauma history is what you'll see with the corneal abrasion patients. It could be a little one like this. When you use fluorescein dye, you'll see it stain. Now, do you see the difference between these 4 pictures? The one in the lower right, it makes these vertical tracks. So this abrasion looks highly suspicious for a foreign body on the eyelid. So whenever you see these vertical tracks, there might be something underneath the eyelid still there. So always flip the eyelid, look underneath for a foreign body in these cases. When you work them up, you just give them some proparacaine. It will relieve the pain immediately usually, and that is one of the tests that you can do that points to an abrasion. That one picture on the lower right, when you lift up the eyelid, you'll sometimes find a foreign body underneath there. So check for foreign bodies. It might not just be an abrasion, it might be a foreign body along with it. So we don't prescribe the anesthetic, and here's the reason why. The anesthesia is great to do our examination. It might numb the eye for 10 to 20 minutes so we can take a look without the patient being too uncomfortable. But if they were to go home with that anesthesia and use it all night long for the next day, it delays all wound healing on the cornea, and it eventually causes the cornea to melt. So that's why we don't prescribe it. We once had a patient years ago take the bottle of proparacaine home, stole it from the office, and the next day came back with a huge corneal ulcer with melt. So definitely don't prescribe the anesthetic. That's solely there to do the examination. We treat usually with a topical antibiotic, especially if it's a centrally located abrasion, so it doesn't get infected. If it does get infected, the abrasion will lead to an ulcer, and that causes permanent vision loss and disability. That's why we recommend no contacts and lots of lubrication. We're talking every hour or 2 with the preservative-free tier. What do people do for pain? A lot of the narcotics do not touch the pain at all, so unfortunately the patient just kind of has to wait for it to heal. We'll do supportive therapy with cool compresses and ice packs. Lots of lubrication, that's key. So next case, number 4. This one's pain, but it's happened a little longer. It's been going on for a day or 2. And you look, and you see this white spot on the cornea. You might see conjunctival hyperemia. This points to something a little different than an abrasion. It also, when we use fluorescein, will stain, like in the picture there on the upper left. In the more severe presentations of this, you'll see this white layering here. and that's called a hypopyon. So we have a white spot on the cornea, we have conjunctival hyperemia, and we have a hypopyon. And that is almost classic for corneal ulcer. So notice the difference. The difference between an abrasion and an ulcer. An abrasion and ulcer will both stain with fluorescein. The abrasion will look clear, but the ulcer will look opaque or white. The ulceration goes deeper, and the ulceration usually has a bacterial or other infectious component to it. She's got it. Good, thank you. Any questions on ulceration? Okay. Ulceration, depending on the cause, will usually be treated with antibiotics or antivirals or antifungals. There's often associations with infections on those. So next case scenario, this is a patient with on and off red eye. It's been going on for weeks. And you look at them even from far away, their eyelids are red, inflamed. The margins have debris and buildup. Look at this, that gland is all clogged. Here's another meibomian gland all clogged. This is classic for a blepharitis patient. Let's go to the next slide. So on a slit lamp, if you look really carefully, you'll see this buildup of keratin or collarettes where the eyelash exits the eyelid margin. And here's some more examples of it. When you look at the margin, you'll see the meibomian glands here spaced about a millimeter apart. And you compress it, all this thick meibum oil will be released. That's pretty classic blepharitis there. This is probably one of the more common causes of chronic red eye. If you look on structure, you'll see the skin, the hair follicles. Right next to the hair follicles are the meibomian glands, and you have maybe 30 or so of these that line the eyelid like a picket fence, both on the top and bottom eyelid. And this is where we see that inflammation for blepharitis patients. So you can actually, with technology, image the glands now with meibomian imaging studies. And in a healthy eye, the eyelid will show a whole linear row of these meibomian glands, like a picket fence. They produce the healthy lipids for our tears. And through time, if there's chronic inflammation, dry eye disease, or blepharitis, we begin to have meibomian atrophy. They begin to die off. And like in this lower one, you have a couple of those meibomian glands are dead. They're gone, and they're gone for good. And they don't grow back. And some of the ones here on the edge have truncation, and you can tell this eye is a little bit further along on the disease severity scale than the one on the top. Now sometimes if you really look carefully, the ones that have that buildup on the eyelash margin, that is a collarette. That's one of the clinical features of Demodex infestation. And patients with chronic blepharitis or ocular rosacea are at a much higher risk for that. We'll sometimes take a biopsy of that eyelash to look to see if there's any Demodex infestation there. We did a video short on this a while back. You can find it on YouTube. So here are some of the Demodex mites. We can actually visualize these on a microscope right at the patient's bedside. And I think I need one more. I literally see it move around there. If we can go to the next one. Here's another example. This is a bubble, but there are several Demodex on the hair lash follicle that we see with a clump of keratin on the side. So in a wet mount, you can visualize the mites. Let's go to the next slide. Here's some pictures of some of the ones that you can just find online pretty easily. Crawling around. Yeah, here's a picture of a skin, and it's kind of a representation of the eyelid or eyelash follicle and hair. And they'll dive down and they eat the oil, apparently, and the dead keratin or bacteria that are on our eyelid margin. So sometimes you can actually see their tails popping out of the skin margin on the slit lamp examination with higher magnification. Here's kind of a representation. They have 8 little legs, 4 on each side. There's their head and a long body or tail in a cigar shape. A good way to treat it is with blepharoexfoliation. We use a medical grade microsponge on a tool that exfoliates that surface of the eyelid margin where those Diabetics create a home. The other home remedies that we always tell our patients are warm compresses, eyelid cleansers. That should be the mainstay of treatment for anyone with margin disease, meibomian gland disease, or blepharitis. Even when they're feeling great, they have to keep up with that to prevent another flare-up. So if things get really bad and the meibomian gland closes completely, then you end up with this. This is the patient that presents with a stye, swollen eyelid. Usually they'll call you after a day or two, or sometimes after a week, and this is what they look like. It's a swollen eyelid. It represents a blocked gland along the eyelid. Our normal treatment, we've got warm compresses like the Bruder mask. Sometimes we'll use antibiotics to reduce the bacterial burden on the eye. Some antibiotics like doxycycline have a secondary effect, the matrix metalloproteinase effect. Sometimes that's thought to open up some of the meibomian glands. Some of the chalasia will inject a steroid right into the lesion, so that's intralesional steroid injections. And then, of course, the exfoliation. Blefx, great way to reduce the bacterial burden, reduce the biofilm that's blocking the pore, and these are some of our usual techniques for treating styes. The really bad ones that don't go away, that create a loculated mass on the eyelid, these are the ones that are lanced open. The way that works is we use a clamp. It clamps the eye, it flips the eyelid over, and after it's been numbed with an anesthetic locally, we use a blade to lance the center of it open through the eyelid to get the clogged oils to drain. Hopefully we get the patient some relief before it gets to this stage. Now, after the chalasian's been removed and after the blepharitis is maybe a little bit more stable, here's one of the treatments called LipiFlow. We use this single-use applicator. It's a high-tech device with a microscopic bladder on it. There's a protective shield that protects the cornea, and then there's a warmer inside it. It connects to the eyelid like this, hugs around the margin of both the top and bottom. And once this is all set up, we click a button and the machine is automated. It heats internally and has a gentle massage through an algorithm to gently express and cleanse all the clogged meibomian glands along the eyelid margin. So gentle compression through an algorithm to treat the core issue of glandular disease, which is the actual glands. We can move along. Questions on that at all? Blepharitis, meibomian gland disease, on and off redness, rosacea, chalasia, they're all intimately linked. So next, we have a patient with chronic red eyes. Been going on for years. They usually, not always, but they'll usually have a history of LASIK. They might have a contact lens history. And they've tried it all over the counter, and none of the over-the-counter eye drops are enough now. The eyes are always red when they wake up. So this is in that broad category of dry eye disease. You have to remember there are many layers to the tear film. There's the mucin layer, there's the aqueous or water layer, there's the lipid layer, and the lipids are, as we just talked about earlier, created by the meibomian gland. So when you think about dry eyes, this is why not every dry eye patient has the same symptom, and that's because some people have aqueous deficiency. Some people have meibomian dysfunction. Some of them have issues on production, some have issues with drainage, and some have issues with quantity or quality of tears being produced. So broad category, I think dry eye disease is a little bit too general of a term for some of the patients. And they'll ask, well, why are you calling it dry eye? My eye's watery. And that's because I think this is a term that eventually we're going to have to be more specific about talking about it with patients in the future. It might be ocular surface disease or some other term that would better explain it to the patient. So here's a picture of all the particles that are in our tears. You've got electrolytes, proteins, cytokines, the mucin, the lipids. It's very complicated. And some studies say that maybe 80 to 90% of all eye doctor visits across the US are patients that have ocular surface disease. It's a common problem. 30 to 50 million people with dry eye disease, and maybe only half of the people even know they have it. They might not even know. They just are walking around with a red eye and they just cope and deal with it. And only about 1.4 million are actually being treated for the disease. So this is especially after COVID, when everyone started to use their digital devices a lot more for Zoom calls. Dry eye is the next pandemic in ophthalmology. It's a huge problem. You can do further testing for dry eye. We do tear lab osmolarity testing. The easy way to remember it that I think of, a number greater than 300 is not good. So you get a patient, you get a 308 or 300 or higher, that's not a good sign. Moderate, maybe 320, and the really bad cases are 340. We'll have patients that they're above range. Like they're not even measurable because they're off the chart. So if tears are hyperosmotic, then there is reduced water content, or in other words, increased salt content of the tear, and that causes chronic damage to the ocular surface. So this will change moment by moment. If we measure someone in the morning, right when they wake up, it'll be a little different. Later in the day, it'll change, maybe after they exercise. So it's a number that fluctuates a bit throughout the day. In ophthalmology, maybe an example would be like eye pressure. That can go up a point or two throughout the day. There's trends that happen. So just like we look at trends with eye pressure for the glaucoma patients, we can look at trends with our dry eye patients with osmolarity. Maybe they're having a few weeks where they're doing great work with their warm compresses and their home therapy. Their osmolarity, we're hoping, will trend more into the normal range, versus those moments when they're having maybe other systemic disease flare-ups. They're not doing their compresses and their home therapy as well, and their osmolarity will start to trend upward. Our next test that we'll run is inflammadry. This is a test that looks for MMP9, matrix metalloproteinase 9, and this is a cytokine marker that is produced when there is inflammation or damage to epithelial cells. So when we have a patient with a positive inflammadry test, that's a signal that they have more of an inflammatory process to dry eye. So it's not just low tear production or low aqueous deficiency, it's also an inflammatory dry eye. So this is kind of a unique category. Sometimes you can get a positive MMP9 if there's a active blepharitis or active infection going on. But if there's no active infection and we have a positive MMP9, then that's usually a sign that they have an inflammatory dry eye. And a lot of our autoimmune patients will have positive MMP9 testing when we do our initial consultation. So next thing to talk about with the chronic red eye patient is allergies. It's a big problem for us out here in the desert, especially when we have a big rain year like we had this time. The super bloom happens after the rains and everyone starts to come in with red, itchy eyes. We have the golf courses. They do the scalping in the fall, and then everyone comes in with their red eye flare-ups. So allergy testing is interesting because some people say they have allergies, and you do the point testing, and it turns out it's not really allergies. It's negative allergies. It's actually just regular dry eye. And some people say they don't have allergies, but you do the point testing for allergies, and they're allergic to half the things on that list. So allergy testing is very important. Some people assume they have allergies when maybe they don't. Or some people assume they don't have allergies when maybe they do. So allergy testing can be very helpful for the patient with chronic, uncontrolled, red, itchy eyes, or the dry eye patient. Such a debilitating problem. If you go online, if you have a Facebook, and you go to the dry eye support community, you're going to see all kinds of comments, and if you read through it, it really is an eye-opener to see what types of effects this dry eye has on someone's life. And other people might say, well, it's just dry eye, it's no big deal. Insurance companies say, well, it's just dry eye, it's no big deal, we're not going to cover your restasis. But it is a huge deal. It has such a huge effect on people's lives where they can no longer work, they can't look at a computer, they actually physically become depressed because of the severity. Look at this. Is it normal to change your life drastically? This patient says, I can't drive. I have to stay all day home with the blinds closed. This is the worst of all my health issues. How do you cope? Let's go to the next one. Some of these other comments, what am I going to do? I'm a single parent, 2 kids. I have to put them through college. I have to resign. I can't even go to work to read my emails. It's too painful. So it's difficult, and it causes such a huge disruption in people's lives. And when we have our dry eye patients, it's really important to listen to them, to find out how much this problem is having in their life. That way we can really address them at the level that they need care, at that level of care. So our aqueous deficient dry eye, we really look at their medical history. Many of these systemic diseases have associations with dry eye. A lot of the heart medications exacerbate dry eye. Antidepressants, antihistamines, diuretics, all these medications can exacerbate the dry eye patient. So a complete history is needed for the dry eye patient. We can't just tell them, here, use your tears, see you later. It really is a lot more complicated than that. Here's some more slides we pulled off of the Facebook group online. I mean, this patient's talking about suicide. They're so severe with dry eye. It's bad. This patient's complaining, well, how come you can beat cancer, but you can't beat dry eye? And that's true. It is a chronic progressive disease. We do not have a cure for dry eye. But when we talk to patients, we do whatever we can to empower them with the tools to treat it so they can regain control back in their life. And that's a critical portion of dry eye. It's empowering the patient to treat it. So, why is it so much frustration, it's complex. There's not always a correlation with the exam and the clinical features. We might take a break in a sec. Are we still on? Yeah, we're still on. Okay. There's poor correlation with the symptoms. There's maybe poor understanding by physicians about it. And sometimes there's misguided treatment strategies. We'll have the patient that'll come in and they'll say, well, I use Lumify every 2 hours when I have this problem. And that's just treating the symptom. That's just treating the redness. We have to really treat the deeper issue, whether it's an inflammatory problem, whether it's a meibomian gland problem, dietary reasons. We have to look at it all. Even systemic health, there could be an autoimmune condition that's undiagnosed or a thyroid issue that's undiagnosed. So more advanced therapies, just so that we can help encourage our patients. There's a lot more you can do. There's punctal plugs, blepharoexfoliation, we talked about that, LipiFlow IPL. There is biological therapies like amniotic graft therapy, Procara, Ambiodisc, and then there's autologous serum eye drops. So there's so much you can do for this depending on the type of dry eye, the subset of dry eye, and when it comes to patients, giving them these tools are helping them through helping them to navigate through this complex chronic disease is critical. Questions on that? We can probably talk another 3-4 hours about dry eye, but we'll go to the next case. Blunt trauma to the injury. So this patient has a blunt trauma and you look on slit lamp and there's a red hyphema, that is blood inside the eye. Hyphemas come in different shapes or sizes. It is usually, as long as there's no rupture or deep damage, usually treated with topical eye drops. In this case of blunt trauma, it's a lot more severe than just hyphema. Notice the hyphema fills the entire eye, and there is this swelling all the way around, and the swelling looks like swollen conjunctiva. We call that chemosis. To me, it always reminds me of a lychee. But this is a warning sign, is not just a hyphema, there's something deeper going on. And what is deeper is rupture globe. So you're going to look for a bolus subconjunctival hemorrhage, meaning the hemorrhage goes all the way around, or there's chemosis. Let's go to the next one. You're going to look for restricted ocular muscle movement. There's going to be low eye pressure, but don't check the pressure if you see these things. You don't want to put any pressure on it. You're going to see a shallow chamber. You're going to see a hyphema, sometimes can fill the eye. Rupture globe is a true emergency. If you have that type of situation, see someone in a car wreck that looks like that, or see someone that's in a bar fight looks like this is straight to the trauma hospital. Don't stop at go, just go straight there. Other clinical features, if you do a little fluorescein, you will see this streaming effect. That's called the Seidel positive sign. It tells you that there's a leaky perforation in the eye. More severe cases, you'll see the iris point to a perforation. So the mnemonic for that is the pear-shaped pupil points to the perforation. The pear-shaped pupil points to the perforation. And that's because there's a perforation here. Maybe they were hammering in their garage and they felt like something hit the eye, and you look, there's something here, the iris is pointing to it. That's a sign of perforation. That's a ruptured globe until proven otherwise. Here's some examples where it's pointing to the perforation. So we have that pear-shaped pupil pointing to the perforation, but it's also prolapsing. You can literally see some of the iris tissue pulling out of the eye through the laceration. And when you see this pupil in that pear shape, don't touch it. Don't check pressure. go straight to the trauma center. Now this thing here, we've had cases where we'll get a call to the emergency room and they'll tell us, hey, there's a foreign body in the eye. I can't pull it out. Each time I pull on it, the patient jumps. Can you come and pull that foreign body out? And it's not a foreign body, it's a prolapse iris. So anytime you see a pear-shaped pupil, straight to the ER, straight to trauma, and this requires surgical intervention to repair it. We have to reposition the iris, reform the eye, and stitch up the perforation. Now here's some more severe cases of ruptured globe that you'll see on CAT scan imaging. Sometimes we do a CAT scan just to make sure there's no foreign body in the eye, like some metal that perforated, a bullet. In this case, the ruptured globe is pretty obvious. It's a squashed eye. That tells you there's a big problem. And this one, there's internal hemorrhaging that you can see on that. So where did that hemorrhage come from? These are some radiologic studies you can do for ruptured globe. Now, something that lacerates just the conjunctiva but doesn't go all the way through and through, this is called a conjunctival laceration. Some of these are hard to tell, but if you check their Seidel test, it'll be negative. There's usually a subconch hemorrhage, and these actually are great because you don't have to necessarily go straight to surgery. Sometimes you can just watch them, and the conjunctiva will reapproximate on its own just with some antibiotics. So next, case number 9. This patient has a swollen eye for a week, and you look, and it's all this periocular hyperemia, true sign of cellulitis. You're going to see proptosis or bulging of the eye. You're going to see restricted eye muscles. They can't look up, left, right, or down sometimes. And it's going to really hurt when you have them look left or right. And fever is a bad sign. That tells you that's a bad infection. This is a little different than like an orbital fracture because you're going to get a trauma history in the fractured patients, but similar. You'll have a swollen eye, you're going to have limited range of motion of the eye, and some other features, crepitus, infraorbital hypoesthesia. These straight to the ER for CAT scan imaging. That's where we go with these. Now, if a patient has blunt trauma, we always dilate and look at the retina. Sometimes we'll see this. This is called commotio. This means there's bruising in the back of the eye. We'd much rather see this than a retinal detachment, but this is a sign that there was a pretty significant blunt trauma to the eye. This one was so severe it actually ruptured the choroid, and you'll sometimes see a concentric ring that tells you there was a pretty bad rupture here. In more severe cases of blunt trauma, it can completely avulse the optic nerve, and there's hemorrhage coming right off that nerve stalk there. This is a bad sign and a much worse prognosis. So that'll conclude the whole lecture. Broad overview, red eye. If there's any other questions, we'll try to include it on the next lecture. But this was broad overview, 3 main consults, red eye. Jocelyn, any questions that you had? Okay. All right, we'll conclude on that one. And until the next one, see you on next.